I think you can see our slides here. So just see the title below, Challenges and Prospects in Data Processing Sri Lankan Context. So mathematical epidemiology, as we know, it is a combination of two subject disciplines, mathematics and epidemiology. So we can have a formal type of definition for that as mathematical study and analysis of the distribution patterns and determinants of health and disease conditions in a defined population. So if we see these three key words here, you can see distribution addressing about who, when, and where. That means what is the situation that we apply our mathematical model. It may be dengue, it may be COVID-19, it may be any other infectious diseases, some kind of thing. With whom, with when, and where. That are the thoughts that we should consider in the distribution. And next one, pattern, increasing, decreasing, and periodic. Those are more mathematical type of incidents. So therefore, we have to fit certain distribution, certain functions, relationships regarding these kind of aspects. And then determinants, quantifiers and reasons, where we have to see what are the independent variables we have, what are the dependent variables we have, and parameters, combining them together in our dynamical systems. So those are the things that overall we should consider in mathematical epidemiology. And I don't think that we have to concentrate much about this thing, because it is now very familiar thing for any epidemiologist and even in mathematical modeler. This SIR classical thing. Professor Thomas also mentioned very sophisticated type of models. So it is just with the susceptible, infected, and recovered here. But we can't just stop here, because we have so many other questions to answer. Because not only recovered, certain cases are death cases, and some are reinfected, as we discussed earlier. They are recovered from something like immunity. Sometimes without immunity, they are dealing with certain period. So therefore, we have to carefully handle this susceptible group again. There may be exposed, asymptomatic, and symptomatic people. So infection may also be different, preclinical, clinical, and subclinical type of cases. Therefore, we can't just stop. We can't just rely on SIR. We have to move forward in mathematical sense as well as in epidemiological sense. So then what are those challenging compartments we have? Just see this slide, then you can just elaborate what happens here. Exposed, because we know that after getting the infection, until we see the symptoms, we have to spend some time, which is called incubation period. So which is a very critical period, because sometimes we do not know whether we are having an infection. So during this period, we are exposed without knowing anything regarding to that. So we have to carefully handle that. So if you have a compartment especially designed for exposed, we have to be carefully taken with our data. Who are those exposed people? Sometimes through the contact tracing, we can find some of them, and some suspected, we can label them as suspected. Even in epidemiological unit data site, they classified certain cases like suspected. They are hospitalized not because of infected, but they are suspected. Sometimes family members, sometimes neighbors, some kind of situation like that. So therefore, in the data processing, we have to be carefully once we collect and manipulate those data into our models. And asymptotic case. So even after the incubation period, some individuals do not show the symptoms. So they are remaining as asymptomatic, which is the most critical compartment in that sense, because we can relate with them without knowing any risk behind their contact with us. So for COVID-19, this is very much important, because in COVID-19, the coronavirus, the latent period is much less than incubation period. There may be variations, but latent period is much less than incubation period. Latent period means time to be with infectious. That means you can spread the disease. So therefore, we have to be careful, and even we categorize asymptotic, then under which criteria they should look at this compartment. So it is a challenging thing for modelers to distinguish what is happening in this compartment. And then quarantine, in Sri Lankan context also, we can see some of them are self-quarantined, some of them are designated in designated quarantine, quarantined in the designated centers. So these two classifications are important, because sometimes people getting quarantined in centers and thereafter another 2 weeks self-quarantine. So some people get infected, actually infectious during this second period of self-quarantine. So therefore, if you include something into model, we have to carefully handle these two parties. Actually, they are quarantined, but in different two different situations. And it is the same for hospitalized cases as well. In Sri Lanka, we know that if people are getting diagnosed, definitely be hospitalized. They are not remaining at home. But during this hospitalization process also, they may spread the disease. Some of them escape from the hospital sometimes, so there is a risk, something like that. Therefore, we can't just isolate a kind of compartment. I mean, we can't consider it is totally isolated. Some kind of relationship with other susceptibles may be happened, even with medical staff. So that is why we have to be with care. We have to handle the data in these challenging compartments. And epicenter of these challenging compartments. So in mathematical sense, we have two types of parameters, like identifiable parameters and unidentifiable parameters. So this unidentifiable parameter is very critical, because different parameters may lead to same observation. So that means we can incorporate certain parameters in different combinations, but the final result is the same. So then we are at a risk of misinterpreting, because we are inputting something with different setup, observing the same. So then one can interpret according to that set of parameters. But another person can set a different set of parameters but getting the same result. So then his interpretation may be different. So that means the same observation to the people, but we are having two different or three different or many different kind of interpretations. So then what is the true one? Then what is the exact one? So we normally know that every mathematical model is wrong, but some are useful. Therefore, we have to pick the best one out of that. So that is why we have to be careful about these unidentifiable parameters. So I just outlined here a few cases that are coming under our slides. We are going to talk about our data processing context with Sri Lankan case, mapping of contacts, age structured ones, spatial data, testing, health guidelines, and supporting data. So in collection process, in history process, and in manipulation, what should be taken with care? Let's see. So mapping of contacts. So it is very important to have whereabouts. I mean, according to our officers in healthcare and even in military units, they considered many sources to find out the contacts after seeing their mobility after getting the infection. So this whereabouts is very important, not only for COVID, even for dengue. Sometimes we do not care about this, but within the household also. Sometimes, let's say I am getting infected with dengue, mosquitoes are around me. So then within the household, we have a mechanism to spread the dengue. So whereabouts of our location is very important. So in epidemiological unit, we had this exposure history diagram, very sophisticated move, and we should appreciate that they initially provide very useful detail with this contact mapping, exposure history. Then exactly, I just got one screenshot here. Later, if I want, if you want, I can just share that total figure as well. Who are related with whom, and how many number of contacts are found. So this is very useful information, because then healthcare persons also can target for testing, with whom we should go for the testing, and with whom with this suspected category form. So very important detail in that sense. So in our models also, if you model something related to testing capacity and the way of the strength of getting the close contacts, we can numerically quantify something by looking at these kind of data source. And even exposed compartment can be indirectly identified using this. So this preliminary group may be the exposed compartment. And indication of early mitigating efforts, as I said, we can target our testing capacity because of these kind of data source. And picking the delay in tracing. Once we proceed with this kind of a tactic, is there any delay or are we ready with any kind of, frequent testing, frequent cross-contact tracing? So it can be also quantified by looking at this. So for that, continuation of this recording with timeline is very important. We had up to certain, up to 102 patients, we had a clear diagram uploaded in their website. Thereafter also, they might have this thing, but it is not openly there in the website. So anyway, that data is very important. So then age is specific. So we discussed earlier also after the first presentation, time is specific and age is specific cases. So if you come to this age specific cases, in mathematical sense, we can see that susceptible persons can engage, contact with many age group people. So that is why we have to carefully handle this IJ group, because according to the age group, this contact may be different. That is why we assign this alpha J with index J. So if you can fine tune a model with age group contacts with susceptibles, it might be a useful one. So that is why we have to look at for age structured data regarding the infection, regarding the death rate as well. So in mathematical sense, we can deal with, as Professor Thomas also said, together, time and age components together. So then mathematically, we can move into partial differential equations because we have two independent variables there, time and age, unlike general ODE situation. As far as this vaccination and long-term mitigation, this analysis is important because in steady state, once we proceed with time, if you negate the effect of time in long age, and then if you concentrate about timing in the long run, it will be useful in designing vaccinations and mitigation process. Even in Professor Thomas, his presentation, he mentioned that adult age are getting more infected, but in latter section of the COVID-19 pandemic, that younger group is also dominating that situation. So then we have to target our mitigation process with that younger group as well. I think the main reason behind that their mobility. If you have this category of age-specific data, we can take many data sources throughout the period of pandemic from these websites, Worldometer, Johns Hopkins University, and GitHub. So in Sri Lankan context also, we can see what we have and what they publish in their data sources. So then we can compare what should be targeted in Sri Lankan context, that what type of more data are required. This is one such case uploaded earlier. So it is again with age, the share of deaths are given. This is for New York City. So this kind of data is very important in the initial stage, especially because people do not aware, even the health officials do not aware what is going around them. So then if you provide this kind of a data, then suddenly people can realize who is the targeted group, who should be the targeted group. And even this one, you can see in adult group, we see more mortality rate, death rate, but it may not be just due to COVID-19. It may be due to some other reasons as well. So they analyzed some kind of death rate comparison with several diseases. So this kind of a processing is also useful. And this is one of the extracts from publications. This is about distinctive trajectories of COVID-19 epidemic by age, which is in South Korean context. Just see one important illustration is here. You can see this blue colored line. Two peaks are there. So this is the group 20 to 39. So they are dominating the whole process. That is why in this age, this gender comparison also, you can see two peaks are there. But if you go to the age structured illustration, two peaks are clearly seen only in this age group. So that is why I said it is dominating the whole story. But two peaks just came dominantly only for this age group, 20 to 39, not for all. So unless you get this age-specific structures in your illustrations, then only you can see this. Otherwise, you will misinterpret that everyone is getting these two peak situation or the second wave. So it is not like so in Korean situation. So they got this second peak just to this group, maybe due to mobility. So that kind of analysis is very important, even to Sri Lankan cases. And this is another paper which is coming in Nature Medicine, age-dependent effects, transmission and control COVID-19 epidemics. Don't bother about this content here. I'm classifying here, I'm just concentrating here, 3 groups of infected: preclinical, clinical, and subclinical. They classified into these categories, not just infected. I mean, before to the clinical things and within the clinical things, symptoms, and even asymptomatic group. That means subclinical group they considered. And they considered in age group wise as well. Just see here, this indexing I and J running on age groups. So they just combine everything together into their model. So here also that diagram says that. So that kind of data processing is needed. So I think in Sri Lanka also those data can be taken because there is very good data collection in hospital wise also. Later I will show one data sheet of epidemiological unit. You can see that under different hospitals they classified how many number of patients are there. So definitely they will actually produce some good results out of those data. And I just skipped this thing because this earlier we did for dengue, but just to concentrate, you can see we identified one peak in this age group just before to 20 years in transmission rate of dengue. So I mean, even for COVID, we should do these kind of manipulations. And then space data. So I will quickly go to the situation here. Now you can see this diagram, Sri Lankan map. Hotspots are given in red, and next hotspots are given like green and yellow and green. So to see the exact spatial distribution, we should locate exactly with the patients. I mean, what is the exact position of getting infected and getting infectious, because those two might be different. So in the daily reports, even we can include, I mean, not for the public, but they can store data. What is the exact location a certain person get infected, but finally, what is the exact location he got infectious. So because this difference might be a problem if you consider those two together. And prospects on spatial periodicity, we can discuss later even in our discussion session, because Dr. Putra is doing many research activities regarding this spatial matters and even this autocorrelation matters. And if we go to the testing, in Sri Lanka, testing data stored by Health Promotion Bureau, they openly show us sorry, the number of PCR testing. So they just put the graphs there and even the numbers. So then we can locate, we can easily see what is the exact time of PCR day. But we have to be aware with what type of exact timing of infection as well, because there is a obvious delay getting the tested results. So in a mathematical model, if you consider the delaying compartment, compartments with delay, we should concentrate about how much of days are taken to complete a test and record that data into a sheet or something like that for other sources. And newly infected and newly detected. So we experienced that Navy and Navy cluster and Kandakadu cluster. So they are infected just because they are detected, I mean tested. So we have to see this difference throughout this process. And we have targeted tests, random tests. So if you can store data in different manners, I mean different storing capacity, let's say targeted test, how much of positives, in random test, how much of positives. So that difference may be an important thing for modeling. And if we have repeated PCR tests, better to record that, because otherwise we are counting on PCR tests without knowing that we are targeting a same person. So it may misinterpret our modeling results. And sometimes repeated locations in lymphatic filariasis, this happens sometimes because some testing, they target certain regions only. So if you infer them into district or MOH area level, we have to be careful. Even in dengue, this might happen. And we should be careful with that kind of repetitions. If it is repeated, better we just cope with that repetition. Otherwise, without knowing that, we can just count, but it may misinterpret the situation. And healthcare guidelines, many records were there in our websites, even in epidemiology site. They quoted every circular and notifications given by health director and Ministry of Health. They are useful because if you want to take some parameters with regard to these complaints or the behavior of people, and what are the essential measures taken by doctors and other health officials in hospitals, like this PPE, surgical masks, because by those kind of information we can see what is the quality and quantity behind the contacts between patients and susceptible medical staff. Let's say if you are going to take some modeling case like infected cases by relating susceptibles and hospitalized cases, we can negate this, we can ignore this if you have a very quality type of breaking point between patients and medical staff in the hospitals because of good quality and quantity wise good PPE, surgical masks and disinfectants. So in community level also this case is there. We can wear a mask, but who can assure the quality of the mask? Who can assure their behavior, with the mask? Sometimes people do not wear that mask properly. So these kind of things are also important in parameterization, these contact rates. And in my final slide of these outline cases, supporting data. We all know that, as Professor Thomas said, density, very useful parameter, and mobility, city attraction, commuter movements, adjacent regions, those are very useful. Not only COVID infected data, these supporting data are very important to compile together. And weather data. For COVID, it is not that interesting at the moment, especially for Sri Lanka, but in German or European countries, it may be a matter once the winter period is coming ahead. We have to see what kind of behavioral changes will happen there. So in lagging effect, definitely these weather patterns are there, especially for dengue data. We experience every time after the rainy season, dengue escalating. So the clear lagging is there. So this panel data approaches can be done. Later in the discussion session, we can discuss more about that. And attitudes on obeying health guidelines, because that is also a matter, as I explained earlier, complaints. So it is also useful. So just see this clustering integrated methods. Dr. Putra and Professor Thomas also involved with this publication. So later in the discussion, someone wants, we can discuss more. And one publication I found that country level analysis on socio-economic background, they consider not only health parameters, but socio-economic characteristics like GDP and some other income levels and level of corruption as well. So those are the ongoing research in this field now, not just with healthcare. So not just with medical treatment, not just with clinical aspect, not just with our compartments like SIR. So now we have to move forward with this socio-economic thing. And this lockdown and border closure thing, they can be still incorporated because we do not know what will be the next pandemic. We have to be ready with this kind of parameterization and useful results. So hereafter, I will invite Dr. Sanjeev Pereira to continue these slides. This rest of the presentation will catch what we are doing in Sri Lanka in the sense of mathematical epidemiology and what would be in the future as